You know, sometimes in medicine, it's these really early observations that just uh, blow things wide open.
Mm,
Like looking back, you see Fabricius Hildanus building on Guidi's work way back in the 1500s, describing these pulsating swellings in kids.
right. Things we probably call congenital vascular malformations now.
Exactly. And then fast forward, Morgani in the 1700s, really carefully documenting aortic narrowing, coarctation. It just shows how far we've come, doesn't it?
It really does, and it perfectly sets the stage for what we're diving into today, special issues in pediatric vascular surgery. We're pulling from Rutherford's,
Sure.
specifically chapters 185 to 190,
The definitive guide.
pretty much. And the core idea is, well, handling vascular issues in children. It's not just adult surgery scaled down. It's fundamentally different challenges, different considerations.
Absolutely. And that's our goal here. Think of this as your condensed instruction manual. We want to pull out those key insights, the practical stuff you need to know when navigating these really delicate cases.
Pinpointing what makes pediatric treatment unique.
Precisely. We'll cover everything from those historical roots right up to current treatments.
Mm.
So where should we start?
Well, building on that history, Morgagni's work was huge, obviously. But then you had others, like Schlesinger in the 19th century, helping us see coarctation wasn't always just one single narrowing point.
Yeah.
That broadened things diagnostically.
And it wasn't just about the structure, the anatomy, right?
Yeah.
There was that big moment, 1938.
Ledbetter and Birkeland, yeah.
Yeah.
First clinical diagnosis of renovascular hypertension in a child.
Right. High blood pressure linked to kidney arteries. That opened up a whole other avenue.
Exactly. And all this history, it leads directly into a really practical question in pediatric vascular surgery. When do you actually operate?
Okay. That sounds crucial. It's not always straightforward.
Not at all. It's much more nuanced than with adults.
Mm-hmm.
Generally speaking, with very small infants, if it's not an immediate life or death situation, we often try to wait.
Why?
Vessel size, mainly. You're often dealing with arteries or veins smaller than, say, 2 millimeters.
Mm-hmm.
Tiny. Yeah, technically it's incredibly demanding,
Mm.
and historically, the results just weren't as good long-term if you reconstructed that early. Now, things are better. Techniques have improved dramatically, so we can intervene successfully when needed, but the preference, if possible, is often to wait.
Okay, so delaying can be beneficial. Is there a good example of that?
Renovascular hypertension is a good one.
Yeah.
If you can manage the child's blood pressure with medication, delaying the actual renal artery repair until they're at least maybe 3 years old seems to give better long-term success rates for the surgery itself.
And managing it medically in the meantime is usually safe.
In many cases, yes. Significant high blood pressure isn't super common right at birth,
Mm-hmm.
and delaying hasn't generally been linked to major long-term problems, assuming the medication works.
But there must be times when you can't wait.
Oh, absolutely. If that high blood pressure is severe, unresponsive to drugs, and causing things like heart failure or even shock, then you have to intervene, regardless of age.
Right.
So it's always that balance. Risk of operating small versus risk of the disease progressing. And people have done successful renal artery repairs in very young infants when it was absolutely necessary.
Makes sense. A case-by-case risk-benefit call. Now, you mentioned sometimes the opposite is true. Early intervention is better.
Definitely. Thoracic coarctation, that narrowing of the aorta near the heart, is the classic example.
Oh, okay.
Yeah. Early repair is usually the way to go. Perioperative mortality is low. The risk of needing another intervention down the line is pretty low, too, after a good repair. And, crucially, fixing it early minimizes the chance of long-term vascular problems and persistent high blood pressure later in life.
So it's about the long game, too, thinking about their future vascular health. Okay, let's shift gears a bit. Something vital in all vascular surgery, but I imagine extra complex in kids. Anticoagulants, antiplatelets, blood thinners.
You got it. Very complex. We use the same types of drugs often, but how we use them in kids, that's where the differences lie.
What drives those differences?
Well, a child's whole coagulation system, their clotting system, it's still developing, it's dynamic, how they metabolize drugs, clear them from their body. That changes with age. Then there are practical things. Getting IV access, monitoring, finding liquid formulations, diet interactions like with warfarin, even just compliance, getting kids to take meds. It all adds up.
Okay, let's break down some specifics. Heparin, for instance. How is that handled differently?
Unfractionated heparin is, well, it's a workhorse, used it safely for years. During surgery, a standard starting dose usually gets the clotting time, the APTT, where we want it.
Okay.
But the target APTT range is based on adult blood. Young kids, especially newborns, naturally have slightly longer baseline clotting times, so that standard APTT target might not perfectly reflect the heparin level in a baby.
Ah, so you might need to adjust the dose.
Exactly. The continuous infusion rates needed to maintain that anticoagulation are often higher per hour in infants compared to older kids.
Reversing heparin. Protamine.
We can use protamine, it works. But interestingly, we often avoid it in newborns and very young children.
Why is that?
Partly because they clear heparin so much faster anyway. And there's a sort of theoretical benefit. Maybe letting the heparin wear off naturally helps prevent tiny clots forming in those extremely small vessels right after surgery.
That's fascinating. Okay, what about longer-term anticoagulation after the operation?
Yeah, that's evolved. Warfarin, the vitamin K antagonists, or VKAs, can be tricky in newborns. They naturally have lower levels of the clotting factors warfarin targets, plus it's pills only, and breast milk is low in vitamin K. It's hard to manage.
So what's used instead?
Low molecular weight heparin, or LMWH, has become much more common. Generally needs less monitoring than warfarin, fewer drug interactions, lower risk of that nasty complication, HIT.
Heparin-induced thrombocytopenia.
Right, but LMWH isn't perfect either.
Oh, what are the downsides?
Dose response can be really variable in kids, unpredictable sometimes, and, well, it requires injections. That's not always easy for families long term.
So are there other options emerging?
People are looking at the newer oral anticoagulants, the NOACs, but honestly, we just don't have a ton of data on safety and efficacy in children yet. Their role is still being figured out.
Gotcha. What about preventing clots right at the surgical site, especially in those really tiny vessel repairs? Aspirin.
Exactly. For very small vessel reconstructions, we often give aspirin during the surgery itself, usually via a feeding tube, low dose. It helps minimize thrombus formation right at the anastomosis where you've sewn the vessels together.
And the risk is low at those doses.
Yeah, the risk of things like Ray syndrome is considered minimal at the low doses we use for antiplatelet effect. Clopidogrel is another one we're using more, especially after pediatric cardiac surgery. Studies suggest even low daily doses work well for clot prevention in kids.
Okay, so we've covered timing, we've covered meds. What about the actual surgery itself? Anesthesia, perioperative care, special considerations there.
Oh, definitely. Pediatric anesthesia is its own specialty for good reason. First off, temperature. Keeping newborns warm, normothermia, is critical. Their thermostats aren't fully developed.
So warmer rooms, warmed gases.
Warmed, humidified gases, external warming blankets or lamps, absolutely. And just having the right size equipment for every age, from tiny infants upwards, is non-negotiable.
Seems obvious, but crucial. What else is key in pediatric anesthesia?
Airway management is a huge one. It demands real expertise. Understanding the developmental anatomy, how a child's head, nose, throat are different and changing. And it's not just intubation. It's being ready for post-op issues that are more common in kids, like laryngospasm.
That sudden vocal cord spasm?
Yeah, or croup or aspiration. Also, induction starting anesthesia is often done with inhaled gases in kids, unlike IV induction in adults. And recovery, we typically place them on their side, the recovery position.
How's that?
Helps keep the airway clear. Kids tend to have more post-op nausea and vomiting too, so that position helps. And we often give preventative anti-nausea meds, sometimes dexamethasone as well.
Makes sense. Protecting the airway. Okay, let's talk closing up. Incisions in arteries, arteriotomies. Any special techniques for kids?
Yeah, because the vessels are so small and still need to grow, just sewing the edges together directly. Primary closure can sometimes narrow the lumen, cause stenosis down the road.
So you might need a patch.
Often, yes. Just like in adults, you judge if primary closure is safe or if you need a patch to widen the repair site. An interesting point is suture technique. Some surgeons prefer interrupted stitches for patches in kids, rather than a continuous stitch.
Why interrupted?
The thinking is it might allow the vessel wall to expand and grow more naturally over time around the stitches. And obviously, any patch needs to be generously sized to avoid becoming a restriction later as the child grows.
Planning for growth again. What about bypass grafts or interposition grafts, replacing a whole segment?
That adds complexity, yeah. Choosing the graft material, sizing it. Common reasons for bypasses or interposition grafts in kids' limbs include peripheral aneurysms or trauma blunt or iatrogenic, meaning caused by a medical procedure.
And for bigger problems, like in the aorta.
Right, things like abdominal aortic coarctation, mid-aortic syndrome, or renovascular hypertension often need bypasses originating higher ups, maybe from the chest aorta or upper abdominal aorta.
What materials do you use for those, and how do you decide the size?
For those bigger thoracoabdominal bypasses, EPTFE, you might know it as Gore-Tex, is often preferred over Dacron. It's thought to be less likely to dilate or stretch out over time. And the key, you have to oversize the graft significantly compared to the child's current aorta.
To allow room to grow.
Exactly. There are general guidelines based on age for recommended graft diameters to try and accommodate that future aortic growth.
Like putting in a pipe that's big enough for the future. Okay, we've talked a lot about open surgery. What about minimally invasive endovascular techniques? Are they used much in kids?
They're definitely increasing, mirroring the trends in adult care. But again, there are key differences. Angiography injecting contrast dye for x-rays. You have to be really strict about limiting the volume based on weight. For smaller kids, say under 15 kilos, hand injection often gives better control than a power injector.
And access, getting into the vessel.
We routinely heparinize after arterial access in kids under 15 kilos. Ultrasound guidance is standard, using tiny needles and sheaths. One limitation: we don't really have dedicated closure devices specifically designed for tiny pediatric arteries yet.
Are there specific risks with endo in kids?
Access site complications, hematoma, thrombosis, pseudoaneurysm seem a bit more common in infants under a year old. Vasospasm is a big concern in small patients. Sometimes we give intraarterial nitroglycerin prophylactically to prevent it.
Can you treat conditions like coarctation endovascularly?
Yes, you can. But the long-term data suggests higher rates of recoarctation, the narrowing coming back, or aneurysm formation compared to open surgical repair.
So it's a trade-off.
Exactly. You can't just take adult endovascular outcomes, which are mostly for atherosclerosis, and apply them to kids, whose issues are often congenital anomalies. You might get less perioperative morbidity with endo, but potentially less long-term durability compared to surgery.
A really critical distinction. Okay, let's pivot to some specific conditions. Chapter 186, aneurysms outside the skull, supplying the brain. Extracranial cerebrovascular artery aneurysms. What about those in kids?
Right. Definitions are based on size relative to normal adjacent vessels. Aneurysms in the carotid bulb or internal carotid artery. True aneurysms are often linked to underlying things, genetic disorders, maybe inflammatory disease. We also see traumatic pseudoaneurysms.
From injury.
Yeah, blunt trauma or iatrogenic causes, like from procedures in the head and neck, the most common symptom. Usually a pulsatile mass, a lump you can feel throbbing in the neck.
Okay. Then Chapter 187 moves into something quite different. Pediatric vascular tumors.
Very different, yes. The key distinction here is tumors versus malformations. Tumors have proliferating endothelial cells. The lining cells are actively multiplying. Malformations are abnormal vessel structures, but the endothelium is usually quiet, not actively growing.
But they can look similar.
They can, which makes diagnosis tricky sometimes. By far the most common vascular tumors in infancy are infantile hemangiomas. There's a whole classification system, ISSVA, to categorize all these different vascular anomalies, help standardize things.
Infantile hemangiomas, those seem quite common. What do we know about why they form?
Well, the thinking is they arise from progenitor cells, sort of precursor vascular cells. These cells make a specific protein, GLUT1, which is a key marker. Hypoxia low oxygen seems to be a major trigger for their growth.
And they often shrink on their own, right? Involution.
Exactly. They typically go through this natural shrinking phase, usually starting sometime between early infancy and maybe age 4. The rapid cell growth slows, cells die off, and the tumor gets replaced by fat cells, interestingly, possibly from the same original stem cells. This understanding is what led to the big shift towards medical management, like with propranolol, instead of just surgery.
A real paradigm shift. What if they're not just on the skin?
They can be multiple, yeah, and can involve internal organs, most often the liver. If a baby has several skin hemangiomas, you have to think about visceral involvement. Most liver ones are small, no problem, but sometimes large, diffuse ones can cause issues, and they can be part of specific syndromes like lumbar or Facey syndrome affecting other systems.
Do you often need to biopsy them?
Rarely for diagnosis, usually only if it looks unusual, maybe suspicion of malignancy or if imaging isn't clear. Microscopically, growing ones look different from shrinking ones, but they're all GLUT1 positive.
So how are they typically managed, given many resolve spontaneously?
Observation is often the mainstay for uncomplicated ones. But for trickier cases, location, size, complications, early treatment, maybe starting around 1 to 3 months, can be key to prevent problems. For small, superficial ones, topical beta blockers, right on the skin, are often tried first.
But if that's not enough?
Then systemic therapy. Oral propranolol, that beta blocker, is now the first-line treatment. Big studies show it works really well for shrinking them.
Any downsides to propranolol?
Well, you have to watch out for rebound growth if you stop it too early while the hemangioma is still in its active growth phase. Corticosteroids used to be common, less so now because of side effects. Other drugs like interferon or vincristine are very rarely used due to risks.
What about other approaches? Embolization, lasers, surgery?
Embolization might be used for really large, high-flow ones causing heart failure. Lasers have roles pulse dye for redness or ulceration, CO2 laser for airway hemangiomas. Surgery for proliferating lesions is rare now because the meds work so well. If excision is needed, it's usually best timed after involution, maybe age 3 or 4.
That covers infantile hemangioma as well. What about other tumor types in that chapter?
Briefly, there are congenital hemangiomas present at birth, GLUT1 negative, different types like RICH, NACH, PICH, managed differently. Spindle cell hemangiomas, often painful, on limbs, usually just need surgery. Epithelioid hemangiomas, pyogenic granulomas, and then composiform hemangioendothelioma, KHE.
That one sounds serious.
It can be. It's more locally invasive and sometimes associated with Kesselbach-Merritt phenomenon, or KMP. That's where the tumor traps platelets, causing severe clotting problems. Treatments evolved, often using sirolimus now.
Okay, shifting from tumors to a very practical need. Vascular access for kids on hemodialysis, chapter 189.
Absolutely critical. Good, reliable access is lifeline for dialysis. AV fistulas connecting an artery to a vein surgically are definitely the preferred long-term option. That's the push behind the International Pediatric Fistula First Initiative, IPFFI.
Dialysis is common for kids with kidney failure.
Hemodialysis is often the initial treatment for end-stage renal disease, ESRD. But kidney transplant is the most common prevalent treatment long-term, and it offers much better survival rates than staying on dialysis.
So if fistulas are better long-term, why aren't they always the first choice? Why start with catheters so often?
Several reasons. Technically, creating fistulas in really small kids is tough, tiny vessels. Also, kids often get transplants faster than adults, so maybe there's less perceived urgency for a permanent fistula. And you have caregiver and patient concerns, needles, appearance, activity limits.
So they often start with CVCs, central venous catheters.
Far too often, yes. And sometimes those CVCs become sort of permanent, despite the risks, infection, clotting. That's why early discussion between the nephrologists and surgeons is so important. Getting that fistula planned and placed well before dialysis starts, following KDOQI guidelines ideally.
What are the specific challenges in placing those CVCs in kids?
Well, tunneled catheters, the longer-term ones, usually need general anesthesia in kids. Sizing is tricky. No perfect formula. Limited availability of smaller pre-curved catheters. You want good flow, but you're limited by the child's vessel size. We actually use an age-based formula in our practice to help guide size selection. Sometimes you have to manually curve the catheter during placement.
And what about the fistulas themselves? Technical points for creating AVFs in children?
Well, historically, patency rates weren't great, but outcomes have improved a lot recently. Still, having had a CVC before can negatively impact fistula success. Forearm radiocephalic AVF is preferred, like in adults. Vein mapping with ultrasound is essential. Sometimes intraoperative imaging too, because vasospasm is such a big issue in kids.
Right, the vessels clamping down.
Exactly. There are minimum vein size criteria. We always use magnification loupes or my microscope. Standard technique is usually endoside anastomosis with fine continuous suture. Sometimes vein transpositions are needed if the superficial veins aren't quite right.
Okay, last chapter to touch on, chapter 190. Acute arterial occlusion. Sudden artery blockage in a child. Sounds rare, but serious.
It is rare, thankfully, but can be limb-threatening. And again, kids are not small adults here. Their vessel walls are different, more fragile, and the vasoconstriction response is intense.
What usually causes it?
It's very age-dependent. In newborns and infants under 6 months, say, it's most often iatrogenic, related to medical procedures, usually catheters. In teenagers, trauma becomes the leading cause. Spontaneous clots from underlying conditions are much rarer.
Let's focus on those iatrogenic injuries in babies. What makes catheterization risky?
The catheter insertion itself can damage the delicate artery wall, triggering a clot. The size mismatch between adult-sized catheters and tiny infant arteries is a huge factor, often made worse by vasospasm. Other risks include inadequate anticoagulation during the procedure, the naturally higher red cell concentration, hematocrit in newborns, and dehydration. Femoral artery cath carries a definite risk of injury needing repair and is a major cause of limb ischemia in kids. Ultrasound studies after cardiac cath actually show femoral clots are much more common than we used to think, especially in infants under 6 months.
And traumatic arterial injuries.
Less common than in adults, but happens from blunt or penetrating trauma. Mortality is generally lower than in adults, but it is highest in infants who sustain these injuries.
How do you diagnose an acute occlusion? What do you look for?
History and a careful exam focusing on those 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, the coldness. Labs can show muscle damage, check clotting factors. Doppler ultrasound is usually the first imaging step. Angiography might be needed for surgical planning.
And the treatment options?
You've got anticoagulation, thrombolysis, clot-busting drugs, and open or endovascular revascularization.
How do you choose?
For iatrogenic femoral clots, anticoagulation, often with heparin, is common first line. But remember, kids metabolize these drugs differently,
Yeah.
so pediatric hematology consults are key. Thrombolysis, maybe with TPA, is an option if anticoagulation fails, but there aren't standard pediatric doses, and bleeding is a risk. It can be given systemically or via catheter directly to the clot. Surgery or endovascular procedures are usually reserved for limb-threatening ischemia when other things haven't worked, especially in neonates where it's technically very demanding due to vessel size and spasm.
You mentioned spasm being a big issue during surgery, too.
Huge. We use microvascular techniques, sometimes involve hand surgeons. Strategies to minimize spasm include warming, gentle handling, topical vasodilators, but even with best efforts, long-term patency after open repair in the really young ones can be challenging.
What about the long-term outlook after an occlusion?
The main goals are normal limb growth and function. Sometimes, even if full flow isn't restored, collateral vessels develop. But if there's a persistent mismatch between blood supply and the needs of growing tissues, it can affect musculoskeletal development, even without classic severe ischemia signs initially.
Okay, wow. We have covered an immense amount of detail on the special issues in pediatric vascular surgery. If you had to boil it down, what are maybe 2 or 3 of the most critical, perhaps surprising takeaways for our listeners?
First, just reinforcing that pediatric vascular care isn't adult care shrunk down. It demands a unique skill set and approach at every single step: timing, meds, technique. Second, the significance of iatrogenic injury, especially catheter-related, in infants. It really drives home the need for meticulous technique and awareness. And maybe third, the evolution in managing infantile hemangiomas, how understanding the biology shifted treatment so dramatically towards effective medical therapies.
It absolutely highlights the specialization needed. So, for anyone listening who wants to go deeper, the source is right there, Rutherford's, chapters 185 to 190. It's the comprehensive guide.
Definitely. There's far more detail in there than we could cover, and it makes you think, you know?
Yeah.
Well, with endovascular tech advancing so rapidly, what will pediatric vascular surgery look like in, say, 10 years? How will we continue to balance these minimally invasive options with the unique needs of growing children? It's constantly evolving.
That's a great question to leave us with. A truly fascinating field. Thank you so much for walking us through all of this complexity today. Really appreciate your insights.
My pleasure.
And thanks to all of you for tuning in to this deep dive.